It's a great pleasure to introduce Dr. Steve Cunningham, who is a consultant pediatric respiratory specialist from the Royal Hospital for Sick Children, Edinburgh, Scotland. And he's going to tell us all about the exciting things that are happening in CF.
Yes, this is an update in cystic fibrosis. My name is Steve Cunningham. There are some disclosures to tell you about in relation to this talk. They are for Vertex Pharmaceuticals, and I have a personal specific lapsed interest, but more pertinent is this current interest, which is in Vertex Pharmaceuticals that we're going to discuss, and that's in relation to a phase 2 study that's happening in our department at the moment using VX770, which we will discuss in more detail in a little while. Because it's an update and we're going to talk about some exciting new developments in cystic fibrosis, there are some unapproved and off-licensed medicines. I'm going to talk about gene therapy, PTC124, VX770, 809 and inhaled mannitol, and they are not licensed currently. Well, the talk begins really in 1989, and in 1989 this edition of Science came out with this young boy on the cover who had cystic fibrosis, and it was an exciting time really because the CF gene had been cloned and identified. There was huge hope at that time that CF would be cured within 10 years, and that was the great hope and that was the great future. But that didn't materialize, and when it didn't materialize, there was a degree of despondency that went through about 10 years ago. I hope to show you through this talk that over the last 5 to 7 years, actually that's improved quite significantly, and people now feel much more confident that we will have a solution for cystic fibrosis in the not too distant future. What's happened in those 22 years? Well, in those 22 years, the young boy has grown up to become a young man who's been kept healthy really by the regular therapies available for cystic fibrosis. That's not the expensive treatments we're going to discuss just now, but some of the regular treatments with physiotherapy, antibiotics, and good nutrition, and with pancreatic supplements. What we're going to cover in the talk today is what we've discovered in that 22 years and now how that is informing our current practice and how it's informing our current level of research. We're going to talk about pathophysiology and how our understanding of pathophysiology has changed in that time. In terms of therapies, there have been some failures, there's been some success, and there's also great hope for the future, and I hope I can demonstrate that to you today. The challenges that have been faced by people living longer, however, have made us rethink about how we monitor this disease, and that's become more complex over time. And again, I want to demonstrate to you how we are currently trying to monitor patients in view of their increasing survival rate. To understand the pathophysiology, we have to, of course, start by understanding the normal airway. This is a cartoon of the normal airway, and this is the airway surface with the cells on the airway surface in the lung. Overlaying that is this layer of fluid, and within this are the cilia. The cilia are kept within this fluid layer, and of course the cilia work to brush away mucus and to brush away secretions and to brush away mycobacteria that might cause infection, and keeping everything moving makes the lungs stay healthy, and that's what's been considered so important. There is a chloride channel, and the chloride channel, of course, is the cystic fibrosis protein channel, which pumps chloride out of the cell, and a sodium channel which brings sodium back into the cell, and that chloride out, sodium in, manages to maintain the fluid level, this level of water, at precisely the right amount. In cystic fibrosis, however, that layer of fluid isn't present. Okay? You can see down here the fluid layer is lost. The cilia are all crushed down, so they can't work with their wave-like action to move on secretions and to move on bacteria, and therefore there's very ineffective movement of fluid and secretions in cystic fibrosis. This defect is now understood to be caused by the defective chloride channel, and the chloride channel is the cystic fibrosis protein channel, which is here, and that cannot work. Because the chloride channel isn't working, the sodium channel is overactive, and it works too hard. It draws too much sodium back into the cell, and as you're aware, wherever sodium goes, water will follow it, and so the water comes away from the surface of the lung into the cells, and this whole layer is dried out and becomes ineffective with depletion of the airway surface liquid. That causes poor mucociliary clearance, and therefore mucus accumulates and forms plugs. Within those plugs, infection can get a hold and can't be moved on, and that plugging, therefore, with the infection and inflammation, causes this vicious circle of lung damage, and that lung damage ultimately leads to deterioration of the lung and to death. What can we do about this? Well, people have worked very hard over the last 15 or 20 years to really identify how to address each of these problems that have been identified. In terms of the defective chloride channel, there are novel treatments, and we'll discuss those more in a moment, together with gene therapy. For the overactive sodium channel, there are what are called ENaC inhibitors. ENaC is the name of the channel. We're not going to discuss that very much today because work on that to date hasn't been dreadfully successful. There are some more research programs in progress, and that may be one area which comes to fruition in a few years' time, but it's not really current, so I'm not going to go through that, but possibly you want to be aware of that. In terms of the airway surface liquid being depleted, there are osmotic agents and other agents which can try and restore this fluid level so that the cilia can work and brush away all the mucus and all the bacteria, and we will discuss some of those. Poor mucociliary clearance can be helped by chest physiotherapy. Of course, that's a mainstay of treatment in cystic fibrosis. Chest physiotherapy is something which happens to all patients with cystic fibrosis, is a regular treatment. Actually, there is no evidence it works, but we believe it works and we continue with it. DNase or Dornase alpha is a medicine that's been around for 15 years now, and again, it's a mainstay of treatment. It breaks down the mucus and makes it more easy to expectorate. It is an expensive medicine, but it has been very effective both in adults and children in breaking down mucus. In terms of infection, we have antibiotics, and there are no new antibiotics, but there are new antibiotic preparations, and there are new ways of using those antibiotics, and we'll discuss slightly more of that today. Of course, when lung damage is so much that it can't be reversed and it comes to a terminal end stage, then there's lung transplantation. But again, we won't discuss that anymore today. We're going to discuss these three areas: novel treatment and gene therapy, osmotic agents and other agents to restore the airway surface liquid, and antibiotics for infection. This picture is a picture of one cell in the airway, which demonstrates to you the defective chloride channel. Now, the defective chloride channel is the cystic fibrosis protein channel, and that is a product of the cystic fibrosis gene. In terms of the cystic fibrosis gene, if you have cystic fibrosis, there are now there are now effectively 1,500 mutations identified in that cystic fibrosis gene. But to make it slightly easier, they fit within what we call 6 classes of defect. In other words, they cause 6 general problems with the cystic fibrosis protein. This is important, okay, and it's important that we go through this today for anybody dealing with patients with cystic fibrosis, because we need now to have an understanding of this to understand the therapeutic options that are becoming available very soon. There are class 1, 2, 3, 4, 5 and 6. We're only today going to discuss class 1, 2 and 3 mutations. Class 4, 5 and 6 are relatively rare, and we're not going to take those any further. Of course, if we want to completely correct the chloride channel, then what we would have to do is completely place a correct copy of the CF gene back into the cell. That is gene therapy. That is a program that was tried in the early 1990s, shortly after the cystic fibrosis gene was discovered. It wasn't very efficient, and most of those programs, there are about 6 programs worldwide, most of them now have fallen by the wayside. There is one program which is continuing, and that is what I'm a member of for clinical studies both in Edinburgh, linked with London and Oxford scientists as part of the UK Cystic Fibrosis Gene Therapy Consortium. And our study of gene therapy in cystic fibrosis is going to commence its first multi-dose trial in spring next year. So the results of that will probably be available, one hopes, in about 18 months to 2 years' time to identify whether a treatment that would improve care for all people with cystic fibrosis would be available. In terms of specific treatments for the classes of gene defect, then there are a number to talk about today. The first is for class 1 defects, and class 1 defects are this, where the protein within the cell is produced incorrectly. And class 1 defects, an example of genotype of that, for those of you who care for patients with cystic fibrosis, is G542X, and this results because of a premature stop codon. In other words, the protein is not produced in a full length because as the ribosome reads across the messenger RNA, it comes across an area which tells it to stop producing the protein. And therefore the protein is short, it is ineffective, and it cannot work. For those working across different areas, Duchenne muscular dystrophy has a similar problem, and it too has been able to take advantage of some of these developments that have worked for cystic fibrosis patients. It was noted in class 1 mutations that gentamicin, a commonly used antibiotic of course, had an effect in covering up the premature termination codon so that the full protein length could be read. Unfortunately though, gentamicin wasn't very efficient in doing that. It did it sometimes but not other times, and therefore it's gone back to the drawing board to identify a product that might actually work more efficiently. That product is this, which is PTC124, or its trade name Ataluren, and the cartoon at the top here demonstrates how without PTC124 the protein is short, but with that covering up the premature termination codon, the protein reading continues and a full-length protein is produced. That product, PTC124, is currently in a phase 3 trial in Europe and the US, which is ending soon, and one anticipates the results for that at the end of next year. That would be very exciting for those patients who have that particular class of gene defect, which is probably about 5% of the cystic fibrosis population. What about class 2 defects? Class 2 defects, the protein is produced. It comes out of the nucleus, but because it's made incorrectly, it doesn't fold properly. And any protein that's produced that doesn't fold properly, the job of the Golgi apparatus, remembering back to our early days at medical school, the job of the Golgi apparatus is to destroy that protein and stop it taking any further part in the cell process. What has been used in cell cultures, etc., are some molecules, some medicines, which would stop the Golgi apparatus taking this up. And if it was stopped taking up, actually it would go to the cell wall. And when it went to the cell wall, it would work. Not very efficiently, but it would work, and potentially efficiently enough so that cystic fibrosis patients would have some degree of relief. These are called chaperone medicines or correctors. And an example of this is VX809, produced by Vertex Pharmaceuticals. When used in cell culture, this is a very effective medicine and it seems to work very well. When used in some human subjects with cystic fibrosis, it improved sweat chloride. You will be aware that, of course, in cystic fibrosis, sweat chloride is very much raised because of the problem with the gene. And so it reduces sweat chloride, which demonstrates it's having a physiological effect, but it didn't actually produce any clinically meaningful outcomes, disappointingly. And so this medicine probably isn't the one that we're going to use, but there are other medicines now. People understand that this is possible. There are other medicines in development to probably replace 809, which will have a similar function. It's important because class 2 mutations, delta F508, are about 75% of the mutations that are present in the Caucasian population. And so that's the bulk of cystic fibrosis patients that would need to be addressed. So they, at the moment, don't have a specific therapy for their condition. What about class 3 defects? Well, class 3 defects are when the protein is produced, it comes past the Golgi apparatus, and it goes into the cell wall where it's integrated, but it can't open. Cystic fibrosis protein, of course, is a channel, it's a chloride channel, it's a gating channel. It has to be able to open and close to let the chloride in and out. An example of this would be G551D, which again is about 5% of the cystic fibrosis population. And a medicine which would help to open up the gate of the defective protein is called a potentiator. And an example of that is a medicine called VX770. There are a number of studies for VX770, not many of them published, but I'm going to talk about two in particular just now. The first is VX770, they're both in G551D. The first is in adults, and it's just been published in the New England Journal of Medicine just a month or two ago. The second is not published, but has been presented at meetings and is in children aged 6 to 11 years Again, it was over 48 weeks with a twice daily dosing of a tablet. What was hugely exciting about this medicine is that when the first results came out, and within this publication in the New England Journal of Medicine, is that it's one of the first medicines ever to correct the physiological problem. In other words, sweat chloride, which identifies the physiological problem, it has normalized sweat chloride. It's brought it from its high level, which is usually typically about 100 millimoles per litre, and brought it down towards a normal range. In the study, over 48 weeks, the weight of the adults in the study increased by 3 kilograms, again a marker of good health in cystic fibrosis, and importantly, lung function improved by 10% and was maintained at 10% throughout the study. So that's a tremendously exciting outcome for a therapy, a tablet therapy in cystic fibrosis, and everyone was very excited when these results were first presented. Those of you working with children and other diseases, of course, will be aware that it's often quite easy to demonstrate an outcome in adults. It's often much more difficult to demonstrate that a medicine works in children, particularly my field of asthma. It's very difficult sometimes to demonstrate that asthma medicines work in children. So we've been very excited to learn the results of the study in children aged 6 to 11 years, which have been recently presented. And in children too, the sweat chloride is brought back to a normalized kind of level. Weight increased by 2 kilograms, which is great considering the average weight of a 6 to 11-year-old, and FEV1 improved by 12% and was maintained that improvement throughout the study period. So it appears likely that VX770, which is specific for this particular genotype, 5% of the population, G551D, and 1 or 2 related genotypes, that will become licensed in the US and in Europe within the next 12 months. What about other therapies? What about airway surface liquid and how to restore it? You'll remember these cartoons from a few minutes ago, that in cystic fibrosis we have the depleted airway surface liquid, and what we want to do is to replenish that so there's more fluid in that level so that the cilia can work more effectively. There are 2 therapies that we're discussing today. One is hypertonic saline, so high-strength saline, and a study by Elkins in the New England Journal of Medicine. The other is a medicine called mannitol, which we're not going to discuss in great detail today because it's only licensed in adults in the European Union. The results in children and adolescents are far less compelling for this medicine. But mannitol is a complex sugar which absorbs within this layer and therefore draws water into it and can expand the layer. So it has been very effective in some adults. The hypertonic saline study was a few years ago now, but it has garnered more support over time, hypertonic saline. It was a study over 48 weeks using 7% saline, 4 mils nebulized twice per day. What was important about this study was that although the effects on FEV1, so lung function, were relatively mild, one outcome which is of great importance to patients with cystic fibrosis, that is pulmonary exacerbations, was reduced by 56%, demonstrated by these graphs here. The other very important aspect for those of us who work in cystic fibrosis field, of course, is that hypertonic saline is incredibly cheap. Okay, it's a very cheap and readily available option to use with any patient with cystic fibrosis, and for those of you in resource-poor countries, actually using hypertonic saline as a first choice before DNAs probably is a reasonable option. What about infection and antibiotics? There are no new antibiotics, as we said, but there are new antibiotic preparations. These have generally been made available because of ease of use considerations for patients with cystic fibrosis, and also some nebulized options. The first was a replacement for nebulized tobramycin. Tobramycin, nebulized Toby, of course, available for quite a number of years now, 10, 12 years, used predominantly in North America, used in Europe, but also nebulized colistin used in Europe. An alternative now has become available, which is dry powder tobramycin. 4 capsules are taken twice per day through this device, and the company have demonstrated that this is equivalent to nebulized medicine. And so it's an ease of use thing. And I imagine that more of these will become available over time to actually make the burden of disease on cystic fibrosis slightly less, because the treatment time in the morning and the evening is approximately 2 hours for some patients. What about nebulized options? We've had nebulized Toby, we've had nebulized colistin, but bugs become resistant to that, particularly Pseudomonas aeruginosa here, which is one of the most dominant bugs in cystic fibrosis, causing long-term damage. And what about that? We need more options for this because of resistance, and we've got them now, at least for adults at the moment. Amikacin and aztreonam have come onto the market in the last 12 months. They're at the moment for adults only within the European Union, but there are pediatric investigation plans in place, so the pediatric studies, so we anticipate a license for these within the next 12 to 24 months for children. So there's an extended availability of antibiotics by nebulization that are available and coming online soon too. There are more than these in preparation. Another antibiotic which has gained some ground over the last few years that it's important that you're aware of if you care for patients with cystic fibrosis is azithromycin. And this is used in those who are colonized with Pseudomonas aeruginosa. In general, it's given once per day for 3 days per week, so compliance is very easy for patients. And not only is it considered to have antimicrobial activity against Pseudomonas aeruginosa, but it's also considered to have an anti-inflammatory effect. And that anti-inflammatory effect is considered very important in patients with cystic fibrosis. There are a number of studies, but most notably the study by Amanda Equi in children and Lisa Simon in adults. And in both, there was a demonstration that using regular azithromycin in patients colonized with Pseudomonas aeruginosa and cystic fibrosis improves lung function and reduces the frequency of exacerbations. And so azithromycin, which is a relatively cheap option for a medicine in cystic fibrosis patients colonized with Pseudomonas, is now a mainstay of treatment for those patients with cystic fibrosis. So what about monitoring disease? Well, people with cystic fibrosis are living longer. This graph demonstrates it. This is the average life expectancy here against here, so the years long here, with some of the treatments that become available. And you can see that there's been this progressive rise in anticipated median survival for patients with cystic fibrosis. If you're living longer, of course, then your deterioration is occurring more slowly. And this graph demonstrates the deterioration in lung function in patients with cystic fibrosis. Here is FEV1 from 100% down and age here in two cohorts, one cohort in 1990 and one cohort in 2004. And you can see that there's a plateau here before there's deterioration. And if you want to demonstrate that a medicine works effectively, then you have to do it at a point where there's change. And so previously we often demonstrated that medicines would work effectively in this range. But whereas your normal, so less than 80% of your normal lung function, it started to become abnormal about 13 years of age in 1990, that's now more like 18 years of age. And this was 2004. I imagine now it's probably 20 years of age. And so this slowing over time has made it more difficult to monitor the disease and to demonstrate effectiveness of treatments. We've also become aware of what we've called the silent CF years. These are children with cystic fibrosis who appear well, but they have infection and inflammation. They have reduced lung function when we can measure it very precisely, and they have a normal CT scan with bronchiectasis. And the silent CF years start very early. This is work from the Australian group, Arrest CF, a consortium in Australia, looking at CT scan of newborn infants identified by screening at 4 months of age. And at 4 months of age, we already have airway dilatation, we have bronchial wall thickening, and we have gas trapping. So abnormality exists at a very early age in cystic fibrosis, even when patients are asymptomatic. Later on in life, when children are able to lung function and have normal lung function, this is a minimum of 6 years of age, really to begin to get these kind of values, we can demonstrate widespread bronchiectasis and airway thickening. And so CT scanning has become a very important tool to us to demonstrate the effects of cystic fibrosis early in life. But of course, that's associated with a very significant radiation dose, which would need to be limited. What we'd like to understand better are the silent CF years. And one of the ways that we've been able to identify this is with ventilation distribution. This is hyperpolarized helium MRI scans, very specialized scans, only available in 2 or 3 places in the country. And here we can see some ventilation defects, even when lung function is normal. What we need to understand is how to measure this ventilation defect. One way to do this is with what's called a lung clearance index. This is a passive tidal breathing test of an inert gas which is breathed in and then breathed out, and how quickly it's breathed out is a marker of how obstructed your lungs are and ventilation problems. It can be performed in all ages and has the same normal range. This is work from our group, but there's also work in children demonstrating the same thing. What's important about this is that we can identify with lung clearance index people who have a normal lung function but an abnormal lung clearance index. Abnormal is above this line, so these people have abnormal lung clearance index. And that's the first time we've been able to adequately demonstrate that there's abnormal ventilation. So for the silent CF years, we have CT scan, which is limited low-dose schedules. I say it's low-dose schedules, not regular CT scan, maybe every 3 to 5 years as a research tool. We have lung clearance index, which is easy to measure, and a narrow normal range, and abnormal very early on in the disease to give us a clue what's happening. So what's happened in those 22 years? Well, we said this young boy has grown up. In terms of our understanding of pathophysiology, we now understand about the depletion of the airway surface liquid and how important it is to try and restore that. We have a number of therapies, both some cheaper options but some more complex options that specifically target the gene defect, and they're important. And we've learned far better how to monitor the disease at a much earlier stage so we can intervene, and by intervening, hopefully improve the survival rates in our patients. Thank you.